My name's Scott Ball. I'm a orthopedic surgeon. I practice at UC San Diego. I've been in practice since 2006, so about 17 years. Probably about 5 years ago, I started moving from measured resection and more standard mechanical alignment toward more patient-specific or kind of kinematic alignment. And as I transitioned there, and you start putting in a tibial component, say at 3 degrees of varus, that's when I really started seeing more value in having a really accurate targeting device to make sure that if I'm shooting for 3 degrees of varus or 3 degrees of valgus on the femur, that I'm actually hitting that target.
My name is Bryan Emmerson. I'm an orthopedic surgeon in Santa Barbara, California. I've been in practice in Santa Barbara for 12 years, and I started using ortholine roughly 8 to 10 years ago. And I currently use it on all of my primary knee replacements. One thing that I found very helpful was that it's very portable, and so now that I do a large percentage of my surgery in an outpatient setting, this is nice because you can use it in any operating room essentially.
Yeah.
You don't have a large footprint for an additional unit, and so that's been very helpful that I've been able to offer my patients essentially the same surgery, same implant, and same surgical guidance both in the inpatient and outpatient setting, and I think that's been really helpful.
Yeah, same. So we're going to talk about a knee that I did where the patient preoperatively, she's in varus, and this brings up this concept of constitutional varus. How much do you correct somebody? Do you shoot for mechanically neutral, or do you potentially leave them in a little bit of varus? So based on these preoperative plans, she looked to me to be about a 4 degrees mechanical valgus femur, and therefore I would shoot, if the tibia can accommodate it, I would shoot for about 4 degrees of varus on the tibial side, because with those reciprocal numbers, that's going to cancel out and give you a 0 through the knee. Intraoperatively is really where you get the numbers. This just gives me an idea where I think I'm starting. So after I get my exposure, and then I put the tibial pin in, the femoral pin in, and then register the femur, which then gives the center of the femoral head. When I assemble the jig, I start off thinking I'm probably going to be at whatever degrees of femoral valgus, and then I double check it. That's one of the nice things with ortholine is that you can pin it in place, get it registered for the center of the femoral head, put on your distal femoral depth of resection guide, and see where it engages the distal femur. So if you're going to restore, say, the medial side, like in this case, that's the side that's worn, so you're probably 3 millimeters short on the medial side. So I usually will have the distal femoral resection jig. I think is coming up on the video here in a second. But I usually try to have that sitting proud by about 3 millimeters to make up where the worn cartilage and the worn bone were before she had arthritis, to restore that natural joint line. And then I just go back to the ortholine lantern unit. So you can see here, this is now down on the lateral side, if you can see on this video. And then on the medial side, you can see it's sitting proud by a few millimeters. So I'm shooting to have it on the worn side sit proud by about 3 millimeters, and then you can go back and adjust what your angle is, and then take note of that number. So in this case, I had planned that I thought it was going to be 4 degrees. Again, I don't have the standing alignment film up to the femoral head, so intraoperatively I find that she's at 2 degrees actually of valgus on the femur. So I'm pinning that in place to make a 2 degree valgus cut. Carrying that forward to the tibial side, if I'm going to go for total mechanical neutrality, then I would cut 2 degrees of varus on the tibia, because 2 of valgus, 2 of varus, that's going to leave you at 0 through the knee. Again, looking at her, she had a varus thrust on physical exam before surgery, so I know that lateral side's a little bit stretched out. So I know I'm going to be really starting to strip the medial side to balance it on the tibia. And so in this case, I planned to do a little bit more varus on the tibia to leave her at 1 or 2 degrees overall mechanical varus.
One of the nice things, as you've alluded to, is that you can change in real time.
Right.
And so you're kind of getting all these numbers as you go through it, and you really have the opportunity to really dial it in, 1 or 2 degrees here, or the depth of your resection, like you said. I find that when I put the paddles down, particularly in a bad valgus knee,
Mhm.
it is really interesting to see just how much of that distal femur and the lateral condyle is missing.
Right.
And you kind of get a sense, on those as an extreme example.
So Bryan, you've got a varus knee also. I think our philosophies are a little bit different on prepping them, although using the same kind of tools with ortholine. But how do you approach your varus knee?
Yeah. So again, for me, I like to have mechanically, I like to have the tibial cut 90 degrees, orthogonal to the ankle there, to the long axis. And then the femur, I'm willing to play a little bit, but still, I still base that on the mechanical axis. Now that we have the benefit of these navigation aids, I think that's been really helpful along the way. And you kind of work through the curve of, really trusting the device. So this was a 68-year-old gentleman with a varus knee and limited range of motion, 0 to 115. So once I make my exposure, I then freehand the position of the guide pin and calibrate the device. I do like to rongeur off a little cartilage there centrally. I don't know if you do that, so that the device will sit flush. And then we
Are you
take
talking about on the anterior surface, like where the trochlea is? Or?
Yeah, where the trochlea is. Yeah.
I sometimes do that with a saw. Like if they've got a big trochlear osteophyte,
Exactly.
I frequently just freehand a saw just to kind of flatten it. So when you put the cutting block down, it sits nicely.
Yeah. So we calibrate the device, and then I will measure to 2 degrees of flexion. Again, for the anterior bow of the femur, I think you said 3.
Right.
So 2 to 3 degrees. And then in this particular patient, I did put or set the distal femoral cut for 1 degrees of varus, and I measure off the paddles, and then I set that depth of resection based on whether or not they have flexion contracture, or if they're ligamentously loose and have some recurvatum, we take that into account at that point.
Was the 1 degree of varus because you're kind of assuming that there's going to be a little difficulty balancing it because he looked pretty varus?
Yeah. So we anticipate that, like you alluded to, I'd need to do some releases, and I
Right.
find that helps. I think that we really have the benefit of, now that the implant design and the poly is much better,
Mhm.
I think it does give us a little bit more room to play, so to speak, in terms of positioning the implants and a little bit of varus or valgus. So again, I'm kind of, transitioning into that, but still kind of using a classic mechanical axis at the time. So I knew that we would need to do some releases. And one of the things I found with using the lantern and the balance system is that I do some more releases early.
Mhm.
I've kind of sequentially done releases throughout the procedure at varying steps, and I find that now it really makes me kind of front load some of that,
Mhm.
just to increase efficiency. So when I take that measurement, that I'll be that much closer to, where I want to be. When
Right,
I
like once
check
you get your
inflection
trials
extension.
in.
Yeah.
Like get to that point where you're trialing and you don't have to work backwards and
Yeah.
start releasing. Yeah,
Yeah,
because you're getting
exactly.
the data earlier in the case.
Yeah, exactly.
So similarly, once I've got the meniscus out, once I've done just sort of a general first, like in this case, it was a little tight medially based on the block. So I did just kind of broaden that exposure, remove a little bit of osteophyte, and then I put the balance in to check the distal space or the extension space. Okay, so then moving into the flexion gap here, this patient cooperated really nicely. I love this because not every knee cooperates like this. But the flexion space, again, it was just 2 millimeters looser lateral, and to me, that's acceptable. People talk about a rectangular flexion space. I would say maybe 1 extra millimeter lateral, maybe 2. You can use the ortholine balance with the tensioner to actually set the pins. And so when I get numbers like this, and so we have 23 millimeters in the extension space and 14 in the flexion space. So the difference between those is 9. The posterior cut for these normal systems is, I believe, an 8 millimeter cut.
Yeah, 8 to 9, yeah.
Yeah, so if it comes out somewhere around 8 or 9, then I'm just going to go straight to the pins and use that as my pin guide to set my cutting block. So I just dialed that to 9 millimeters, just as that calculation suggested that we should. And they've got that pin guide that crosses implants. So that this is a DePuy Attune, but you can use the pin guide for whatever company so the pins are spaced appropriately. here, as you said, so now we've got the cutting block in. I do the same thing.
Yeah.
Once it's in place, before I make my cuts, I like to just sort of tertiary check, make sure that that same block that fit in the extension space fits appropriately in the flexion space and feels rectangular. And if that space is rectangular, feels well balanced. Now I've got the lantern information saying it looks good, go ahead. I got the block that says it looks good, and so then I pin it and go. And then with trials in place, again, this patient cooperated very nicely. I'm sure you've had those knees where you're going through and the numbers are not as perfect, but this one came out beautifully. And again, that the lantern giving you the numbers along the way, and the spacer blocks agreeing with what the lantern's telling you. That this to me just gave me great confidence, and the trials felt great. So we go on to just cement the implant in place.
Yeah, you talk about the particularly in the tougher cases. I think it's nice in that the measurement tools don't tell you what it has to be. It tells you where you're at.
Right.
So it's one more piece of information that you can make an intraoperative decision. You can slightly change your workflow. You can make some subtle changes, and that's what I like. Is being able to change everything in real time. So I think that's been helpful. Similarly, we'll measure before I make my cut, and we'll check rotation as well as the measurements of the medial and laterals.
How much do you allow the balancer to dictate your femoral rotation? Sometimes you've cut tibia, you've done some releases, you get into the flexion space, and you find that it's suggesting 7 degrees of external rotation, or it's suggesting 2 degrees of internal rotation, probably because of either inherent, ligament instability because of the arthritis, or sometimes probably we iatrogenically release the medial side, and maybe that loosens things up when you go back into the flexion space.
Sure. Yeah, and again, I like it in that I get the number, and I get to decide what I do with that number. Yeah. And so, when I look at that value, it's unlikely that I will internally rotate a femoral component. I tend to keep it at, externally rotated between 3 to 7.
Okay.
And I might I might start it at 0.
Right.
But if you look at the vast majority of my cases, I'm, externally rotating somewhere between 3 and 7.
Yeah.
And, I think that time will tell. One concern would just be patellar tracking.
Right.
So I would not want to have a subluxated or laterally tracking patella if I were to overly internally rotate. So I think you have to kind of take all these numbers with a grain of salt.
Right.
And it's up to the surgeon to make the decision, ultimately what's best for the patient. But I believe this one I put in 3 degrees of external rotation,
Gotcha.
Which would be kind of a standard,
right,
for a
standard
varus
position.
knee. So this shows a recovery room film from my patient, varus preoperatively. And here we can see the tibial components neutral along the mechanical axis there, and an appropriately placed distal femur. The measurements that I got, very similar to your case, intraoperatively fit very well. We were within 1 millimeter of the measured flexion space and extension space were essentially equal. And then anecdotally, the composite thickness of the femoral implant with the tibial tray and the poly was within 1 millimeter of what the device had measured.
Mine on the this case of mine, same thing. I did minimal, as I said before, just kind of went around the medial side. I didn't have to do any sort of fenestration or pie crusting or anything like that. Pre-op, probably 10 degrees of varus, and then kicked her back to pretty much mechanical neutral. That, again, not a standing alignment film, but I think that probably will end up measuring 1 or 2 degrees of overall mechanical varus from center of head through the knee to the ankle. But on the X-ray, it looks like a nice correction, nice neutrally aligned knee.